Hello, everyone. My name is Don Self. For the last 38 years, I've been a reimbursement consultant, billing expert, coder, author, seminar leader. I think I've taught about 950 seminars and webinars. Now, today we're going to be talking about the 2023 Prolonged Service Codes. How are they going to make a difference in your practice? I'm kind of excited about these things, by the way. So what are the prolonged service codes? These are additional codes that you can be billed out for the time you spend past and beyond the normal time you spent on an E&M code. They're pretty easy to use, really. In fact, when you're filling out your claim, you're either going to do them one of two ways. One, you're going to add them with the E&M code and build out on the same day as the E&M code, times however many units that you get to bill them, or you're going to bill them out by themselves on a claim form in conjunction with a E&M code that was done on a previous day. I'll go into detail on each one of those and it will make sense. When you're using these right here, if you're going to use the prolonged service codes, the majority of them, you must have used time to determine the level of service. Now, when I say that, you need to understand that there will be instances when you're going to use time. There'll be other instances where you're going to use medical decision making to select the level of code. But for these, you can't use medical decision making to have selected the time and then add on another prolonged service code. It doesn't work like that. Now, what codes are we talking about? For Medicare, we're talking about 4 different CPT codes or HCPCS codes: G2212, G0316, 17, and 18. And then commercial carriers are going to have other codes. But for the Medicare codes, we'll talk about those first. The G2212. This is a prolonged service code you're going to use in conjunction with an office or other outpatient visit for Medicare. Again, this is Medicare only. Medicare's average allowed amount in the country this year in 2023 is around $32.92. Obviously, it'll be more in some areas like New York, California, Alaska, the higher areas, and it will be less in some areas of the country like West Virginia, Indiana, Mississippi, etc. So it's going to vary just like the rest of these. And these codes right here can be used by physicians or non-physician practitioners. So the G2212 you're going to be using for place of service 11 or 22. It only includes the services being done on that date of the visit, no additional days with Medicare on this. And you only use it in addition to the highest level CPT code, 99205 and 99215 for the office visit. Okay, it's pretty simple, just limited to those two, exactly. It also requires a full 15 minutes have been spent. You can't bill it out if you've only reached 10 minutes or 14 minutes, etc., which indicates we better start getting into the habit of documenting time. And by the way, when we're talking about documenting time, I highly recommend, if you're going to build out prolonged service codes, that you document start and stop time. That's going to be safest. We haven't seen Medicare or any of the commercial carriers come back and require it yet. They used to on the other codes, the 99354, 99355, etc. They required it. So we kind of expect that they're going to be requiring it on these as well. So how much time is needed? Well, the 99205 is going to be for Medicare, 60 to 88 minutes would be a 99205 by itself. That time changes, by the way, on commercial carriers, on the highest level. So for Medicare, once you've reached 89 minutes, then you could bill out a 99205 and a charge of G2212. Or if you've reached, 104 minutes, then that'd be a 99205 plus 2 charges of G2212, because there's no limit on the number of units you can bill out on the prolonged service codes with the AMA CPT or with Medicare. So a 99215 is typical time, 40 to 88 minutes or 68 minutes for Medicare. So once you've hit 69 minutes, you could bill out the E&M code plus a G2212, G2212. So that's a G2212 for that's the office, so 99205s, 99215s. What about the G0316? This is for hospital, places of service 21, which is inpatient, 22 outpatient, or 23 emergency room. And just like the other one, with Medicare, it's at least a full 15 minutes. G0316 would only be used with the highest level hospital codes. So you're only going to use it with the 99223, the 99233, or the 99236. You may say, what's a 36? 36 is an admit discharge on the same day, and that's the highest level. Just like the others, it requires a full 15 minutes before you can charge out a bill for the G0316. minutes. So your times on this one's going to be until you hit 105 minutes, you really don't have it. But once you have 105 minutes, you can bill out a 99223 and a GO316, or 99233 is 80 minutes plus GO316. Well, it's going to take 125 minutes to be able to get to use the prolonged service code for the admit discharge code. Remember, these will build in addition to these other codes that I just have listed there. Now, if we're talking about a skilled nursing facility, in 2023, you've only got 4 places of service. You've got office, you've got hospital, you've got skilled nursing facility, and you've got home. So a skilled nursing facility is a place of service 31. So the prolonged SNF E&M service beyond the maximum required time of the primary procedure. So just like the others, a minimum of 15 minutes. It can be billed out also by the physician or the nurse practitioner or PA, so the non-physician practitioner. And you're only going to use this with the highest level skilled nursing facility code, 99306 or 99310. As the others, it requires a full 15 minutes. So at 45 to 94 minutes is the normal times for Medicare for 99306. You keep saying for Medicare. That's because when we get to commercial, you'll see their times are different. Seriously, I didn't know that. That's why it's so important you understand it. Many times Medicare has one set of rules and commercial has something else. So that's why with these codes, we're giving you Medicare's rule. So in order to get to a time when you'd use a GO317, you're going to need 95 minutes in addition to the 99306, or 85 minutes if you're billing it out for the subsequent visit, 99310. And you sit there and say, now these times right here don't seem normal to me. They didn't either with me until I double-checked, triple-checked, and quadruple-checked with the Federal Register from October 28, 22, and it's table 24, and it gives you these exact times that's in there. So if you need to, you can verify. What about the additional time? The skilled nursing facility does not include just the date of the visit. It also includes the time spent the day before the date of visit, plus 3 days after. You may be wondering, do I need to hold my claims? I highly recommend you hold your claims to at least the 4th day. Because let's say the doctor reviews the progress notes before they go to the skilled nursing facility the day before. Then the time that they spend all on the date of visit before they walk into the room, once they see the patient, after they've left the room and they're documenting everything and ordering tests, etc. Maybe they ordered some additional diagnostics or labs that may not come in for a day or 2 or 3 days. Those all come in 2 or 3 days later, or the staff from the nursing home calls the doctor and asks questions, and the doctor makes decisions. And again, when I'm talking about doctor, I also mean medical providers such as a nurse practitioner, PA, that's doing the service. So they may be making changes 2 or 3 days after. All of that gets counted in on the time. So if all that time right there equates out to be 95 minutes, then you have a 99306 if it's an initial skilled nursing facility, and the GO317, and if it was 110 minutes, you'd be at 2 charges of GO317 because there is no limit on the number of units. What about when the patient's in their home or residence? That's going to be place of service 12. Remember, home can be the patient's house, an apartment, assisted living facility. It can be a domiciliary rest home, can be a campground, cruise ship, wherever the patient happened to live, hotel, etc. So the prolonged service code is going to be the G0318. And Medicare's allowed, as I say, is 3186. This also is a minimum 15-minute code, and you'll use it with the highest level of home visit code. You say, what happened to the assisted living visit codes? Those have gone. Now you're going to be classifying everything like that that's outside of skilled nursing, a hospital, or office as home or residence. And that's code 99345 for the initial and 99350 for the subsequent. Full 15-minute codes, as I said, so the first 75 to 139 minutes would be a 99345. So once you've reached 140 minutes, you could bill out a prolonged service code on top of the E&M code. Or if it's a subsequent established patient right here, once you've reached 110 minutes, you can bill it out. Because you sit there and say, now, where would I find this again? You're going to find this in the same table I mentioned a moment ago in the Federal Register from October 28. Now, this one right here includes something separate. We get to count 3 days prior and the date of visit plus 7 days after. Wow, that's a lot of time, exactly. So you make sure you hold your claims for that full 11-day period right here, because you want to make sure that if you're doing something 2 or 3 days before you make a home visit on the patient, or the time spent for the patient's family calling, You're ordering tests before you go out to see the patient in their home, plus the date of service on the date of visit, and then up to 7 days after. All of that's going to be counted. So it's going to be very possible that you may end up having 2 or 3 units GO318, and there's no limit because you're going to keep track of all of that time during that 3 days prior to date of visit plus 7 days after. What about additional codes for commercial carriers? Well, you've got these codes, 99358, 59, 99417, and 99418. These are all going to be for the commercial prolonged service codes. So the 99417, that's what you're going to be using in the office or outpatient. You'll be using that each additional 15 minutes again. Now, by the way, this code is each 15 minutes, but something to keep in mind, as you use these right here for the office visit, anything 1 to 15 minutes gets counted on commercial carriers. Okay, so if I spent 10 minutes extra, yeah, if I spent 5 minutes extra, exactly. Here's an example. 99205 in the CPT code book is 60 to 74 minutes. So if you've hit 75 minutes, then you have an office visit plus the 99417. Same thing with the established patient. If you have 40 to 54 minutes for that, so if you've hit 55, you get to count a prolonged service code 99417. Those times are different than they are for Medicare because Medicare required a full 15 minutes before you got to this. I've already calculated in the numbers here for you to make it simple. And just like with Medicare, there's no limit on the number of visits or prolonged service codes that you can bill out. So 99417 is going to be used for outpatient office or just outpatient, as I'll show you in a few minutes. And 99418 is going to be hospital codes, prolonged service. So it's going to be the 21, 22, or 23. You use this for the highest level of hospital visit code, 99223, 33, or 36. And you're going to bill this right here in the 1 to 15 minute increment as well. So if you've reached 1 minute, 5 minutes, 10, 14 minutes even, we get to count it. So the 3 levels of hospital code, highest level would be initial, 90 minutes, subsequent, 65, and admit discharge. Now, but these aren't the only times you're going to use the 99417 and 418. If we're talking about a skilled nursing facility, we're going to use 99418 for that one also, just like the others. So instead of a 99306 or 99310 by itself, if you've hit 1 minute beyond the normal time, you get to count this right here. 60 minutes would be a 99306 plus 99418. Or if it's a subsequent patient right here, 60 minutes also. You sit there and that's strange. They have the exact same number of minutes. Exactly. Now you'll notice something over here. For skilled nursing facilities, it's a date of visit only for commercial. You sit there and said, well, Medicare included the other days. Yes, that's why their numbers were so much higher. Well, with commercial, you get to use it immediately at 60 minutes automatically, regardless if it's an initial, a subsequent, or a new or established patient. Okay, 99417, as I mentioned earlier, is outpatient. So we're going to use that for the office, or we're going to use that for home or residence. If we're talking commercial insurance, then that's again, we're not going to use this right here with Medicare because the 99417 is a commercial carrier only. You're going to use this in addition to the highest level of home visit codes, and it's going to be a 1 to 15 minute code, just like the other 99418 is. And as an example, a 99345 would be 75 to 89 minutes. So you hit 90 minutes, and you've got a 99417 in addition to the highest level home visit code. And then if you have a subsequent 99350 for an established patient, it'd be 60 to 74 minutes is normal time. So 75 minutes would entitle you to bill out a 99350 plus a 99417. 12 is a place of service. And again, it's date of visit only. Only Medicare counts the extra days. Commercial insurance does not. Now, what about the 99358 and 59? Well, we still have those codes, but they've changed up a little bit. 99358 is still a first hour code for prolonged service before and after direct patient care. And 99359 is for each additional 30 minutes. It's an add-on code. Remember, you don't bill a 99359 unless you also have a 99358 on the same claim. Now, these are both midpoint codes. So a 99358 can be reached at 30 minutes and billed out, and a 99359 at 15 minutes. You don't bill these on the same day as the E&M the way you do the other codes. Medicare classifies these as invalid codes, so we cannot use these on Medicare patients at all starting in 2023. And you can be billed, these can be billed in addition to any E&M code, but again, not on the same date of service. Let me give you an example right here. Let's say that on February 1st, the provider sees a patient and bills out any level of code, 99213, 99214, etc. And they order lab tests, records, etc. And remember, this is commercial insurance. So let's say 4 days later, the lab stuff comes in. On that day, the provider looks at the lab stuff, goes ahead and reviews the lab test results or any kind of other records that might have been ordered of diagnostics, and the doctor decides, or medical provider decides to change the medication and notify the patient, etc. All of that time out there gets counted. And if we've hit at least 30 minutes, then on that date, February 5th, we're going to bill out a 99358. So that would be, let's say, 30 to 74 minutes would be a 99358. At 75 minutes, you'd have a 99358 and a 99359. And those go out on February 5th. There's no E&M code on February 5th because the E&M code was related to this a few days before on February 1st. Now, what about with Medicare? Well, we don't bill these out with Medicare. That's where we have the other ones that we were talking about earlier. This one is commercial carriers only. Which codes were deleted? Well, these codes, and then 454, 55, 56, 57 that we've had since 1996, they're now gone. Are there any other use of it? Sure, cognitive care plan assessment. That's code 99483, and it's a 60-minute code. It is a midpoint code, so that means if you've had at least 30 minutes doing cognitive care plan assessment. Now, let me warn you, there's somebody out there selling a cognitive online test that patients can take, and they say, oh, that's all you need for the cognitive care plan assessment. No, it's not. I teach cognitive care plan assessment to providers all the time, and it has specific requirements that must be met. Average Medicare physician fee schedule on this code is $280. That's really good, okay, the 99483. And it allows prolonged code use. So which prolonged code will we be using this for? I'll use this right here with the 99483. We're going to use for Medicare, the G2212. And if we're commercial, we're going to use the 99417. Now we're going to have different time frames also, as I told you. Medicare is a full 15 minutes before we can bill it. So for Medicare, we would consider 30 to 74 minutes as normal for the 99483. And in order to bill out the prolonged service code G2212 in addition to it, we better document 75 minutes. Now, with Medicare, that includes 3 days prior to doing the cognitive care plan assessment, the date of the visit, plus 7 days after. And again, G2212 typical reimbursements an additional $32. So, but we're getting a really good reimbursement on the code itself at $280. Commercial carriers, though, would be 30 to 60 minutes. So if once you've hit 61, we can bill out a 99483 plus a 99417. That's for data visit only. Well, since a 99454 and 99457 are deleted, what about site codes? What do we do on those? Like the 90837, 90839, where we could use one of these codes that are now deceased. Unfortunately, the AMA and the CMS has not addressed this right here. So we're waiting to see. Right now, unfortunately, the psych and mental health providers are kind of out of luck on those. I'm sorry. I wish I had better news for you on those. But again, that's going to affect psych. Now, we've done something to make things a lot easier for you. We have an EON slide rule. This right here, we're having people order these all over the place because it makes it so much easier. All you do is look up the amount of time that you need right here and the place of service, and it tells you which one of the codes you can use and how many units of each one. We have one side that is Medicare, and we flip it over, and the other side is commercial because the times are different from Medicare and commercial. Again, we're trying to make things easy for you right here. You still have questions? What about this question? Most of these are used with E&M visits. What has to be documented? First thing is medical necessity. Remember, the medical necessity is an overreaching criterion for everything. And basically, we have to give the payer a reason to pay us. What benefit is there to the patient's health? That's what we have to make sure we document. Now, according to the Social Security and Medicare Act, Medicare must have something that shows that this is for the diagnosis or treatment of illness, for injury, or to improve the functioning of a malformed body member. Now, what about commercial carriers? Well, we think we have our own definition, they say. Sometimes you're going to get denials for those commercial carriers, and they'll say, well, this wasn't medically necessary. And you're sitting there wondering what guideline they use. If this is a commercial carrier, it's real easy to kick their butt in there and make the insurance carrier pay and not deny for medical necessity with a simple letter. My advice is to learn ERISA. We've been teaching ERISA for 25 years. Now, documentation being required is if we're going to build prolonged service codes, one thing is, remember, we have to use time for all of the codes other than 99358 with 59 to determine the level of visit, and we need to document the reason for the extra time that's medically necessary. It can't be patient talking about their grandchild, or they're talking about the gardenias or the seasons or the weather. It has to be in there what caused the extra time. Do you still need to document chief complaint and HPI? Yes, even though they're not being being counted, we still have to document them. Remember, the chief complaint is what drives the medical necessity. And this can be documented by the MA, the nurse, or anybody. And for continuity of care and protected practice in case they get audited or they get a malpractice case somewhere, a lawsuit down the road, some HPI is going to be need to be documented. And that's going to depend upon the discretion of the provider, how much. It's not being counted. So we got to protect ourselves in case of malpractice. Now, in previous years, using 95 and 97, we had to have half of the visit was spent counseling and or coordination of care. Not any longer. Now we get to count all of the time doing all of these services here. The time spent with the patient, time before you see the patient, the time spent after the patient. Remember, with Medicare, this might be 2 or 3 days, 7 days later, depending upon the place of service. With commercial insurances, it's all counted as what's on the date of services I'm showing you here on the screen. And yes, you can use some kind of an app online program. We've created one, in fact, on our website. If you want to use ours, you go to donself.com/prolonged. Right now, it's free to everybody. You click on there what kind of insurance there is. Is a patient a new or established patient or an initial or subsequent visit? You'll pick out which different level of place of service, put in a total number of minutes, and then it's going to come out and tell you, based off of all your previous answers, which CPT code and which prolonged service code to use. And you click on this right here as well, and it's even give you the allowed amounts in OVUs if you're set up with our program called Coding Advisor. And it gives you everything from our notes on thousands of codes to the pricing of the allowed amounts on Medicare, any kind of CCI edits, so if there's LCDs or articles limiting you to a certain number of diagnoses. And these right here mean extra money for you. So this is the kind of thing to keep up with. And I hope today's been helpful to you. Hopefully you'll be able to use this right here to make additional income. We hope that we've answered all your questions you have on the prolonged services. Please visit our YouTube channel. Check it out for us and let us know what you think. Thank you so much.